the members here from Henry Schein and everybody else. I'd like to point out to you there are a couple of upcoming webinars that are lying ahead for us in the future in November. There's a PPS follow-up event on the 12th of November, and there will be a SADA Men's Health Evening hosted by a good friend of mine, David Greer, speaking about his experiences running the Great Wall of China, not once, but twice, and how we can endure change in our lives. And then on the 19th of November, the YDC evening is hosted with Dr. Tumbeki Buleni, practice survival strategies during COVID pandemic and beyond the pandemic that we are currently experiencing. With that, I would like to introduce to you Ms. Elmien Greyling from Henry Schein, just to say a few words. Thank you.
Thank you, Dr. van Lierop, and good evening, everyone. Thank you for joining the SADA webinar in partnership with Henry Schein and VOCO. My name is Elmien Greyling, and I'm the Inland Sales Manager for Henry Schein. So as you all might know, Dental Warehouse renamed to Henry Schein at the start of this year, and we are extremely proud to be part of this Fortune 500 company with a footprint in 32 countries. So here in South Africa, our mission is to be the one-stop shop for all of your dental practice needs. So on top of all the consumables that you're all very familiar with, we also have an exciting range of equipment. And you can view it all on our website, www.henryschein.co.za. And then also, if you haven't already heard, we've got a great 20% discount sale currently running up until the 3rd of November. So please reach out to your local rep for all the T's and C's that apply. Some exciting specials to look forward to. And then without further ado, I'd like to introduce Michael Camies from VOCO. He's the area manager for South Africa. So over to you, Michael.
Hello. Yeah, thanks very much, Elmien. I just want to say a couple of words for VOCO. First of all, a warm welcome from the north of Germany. It's cold and rainy outside, so hopefully you're looking forward to a nice summer now in South Africa. Well, a company is only as good as its people, and straightforward, pragmatic, reliable. These are character traits traditionally associated with those born in the region around where our company is based. It's Cuxhaven, situated in the north of Germany, right on the North Sea coast. And there are also features regarded as characteristic of our corporate culture and essential to our success. It's the only way we can explain how VOCO, thanks to the expertise and the dedication of our employees, has developed to become a leading international supplier of premium user-friendly dental materials. As an owner-managed family company in the second generation, our focus is not on quick returns, but on a steady increase in value. We achieve this by consistently addressing the needs and desires of our customers. In return, they continue to place their trust in our high-quality products made in Germany. This also means ongoing investment in research and development, intensive training courses, and a comprehensive range of services for those professionally engaged dentistry around the world. We take our obligation towards our workforce, customers, and business partners very seriously, especially in troubled times like this. Only by cooperating with them can we continue the VOCO success story and keep producing reliable and practical products for modern dentistry in the future. This is our motto as dentalists, specialists in dental materials. Now I have the honor and pleasure to introduce to you Dr. James Robson from Newcastle. I met James for the first time last year at VOCO's biannual fellowship meeting in Cuxhaven. It's a scientific congress where dentists from all over the world are invited to share experience and ideas from their daily work. I was immediately impressed by his sociability and open-mindedness. He also contributed an impressive presentation about his work, which qualified him perfectly as a speaker for this event tonight. Dr. Robson graduated in 1998, has worked in private practice since 2004, and has owned a practice in the northeast of England since 2010. Dr. Robson is a full member of the British Academy of Cosmetic Dentistry and has had articles published in the dental and popular press. Please welcome with me Dr. James Robson and enjoy his lecture. Thanks very much.
Hi there, good evening. It's lovely to be here. Pretty I can't be in South Africa in person this evening, but have to settle for the rainy northeast of England. Tonight, we're going to be looking at direct resin restorations, and our focus is on two specific products, a traditional nanohybrid composite, and we're also going to be looking at a newer style of material called an ormocer, an organic modified ceramic. So if we take a look at those two presentations, so GrandioSO is a nanohybrid composite, and the ormocer, the Admira Fusion. So my practice is up in the northeast of England, a very industrial area called Teesside. And most people, if you talk about Teesside, they think of two things. One would be the sunsets because of the industrial pollution historically, and the other, the bridges. But the bridges offer different ways of crossing the River Tees in different styles. So here, the Transporter Bridge, which carries a gondola across. Here, Newport Bridge, which is a vertical lift bridge, which would clear ships. But it just gives us an idea, a bit like GrandioSO and Admira Fusion, there's different ways of doing the same thing with direct restorations. But sometimes newer materials take a while to catch on. And sometimes when you are the pioneer, you are ahead of the curve. So one of the most famous exports of Teesside, for example, was the Tyne Bridge. But it wasn't until a number of years later when its bigger cousin in Sydney, Australia, allowed things to be more globally accepted in that design. So of course, everyone familiar with the Sydney Harbour Bridge. And the pace with dental advances is getting a lot quicker than it would have been with bridge work. So if we have a look traditionally at how we restored teeth as dentists, it would have been with amalgam. So in the 650s in China, amalgam was around, but being slow to adapt, the Europeans didn't cotton on for maybe another 1200 years. But in the same way composite replaced amalgam in the general landscape, we can do work now in the mouth, replacing it the same. So here just a couple of examples of sort of our daily work with these products. But it's not all at the back of the mouth that we do work, so we want something that's going to be aesthetic as well and strong and can maintain the bite. So we want something that's also suitable for biting edges. If you're looking closely at some of these slides, you may notice the teeth are quite desiccated. And this is a feature of working the rubber dam and having good isolation. But it just emphasizes the fact that I'm very much a real world wet-fingered dentist. So these are live photos of my elderly patients. About 30% of my patients are over 70. I'm in my mid-40s and 70% of my patients are older than me. So we do a lot of sort of gerodontology at the practice on well elderly patients. If we look at the roots of composites, so the first sort of tooth-coloured fillings were in the mid-50s and part of a renaissance after the Second World War, where we had new local anaesthetics, we had implants, we had acrylics, all coming out within that decade following the end of the First World War. But Buenical perhaps being the pioneer in that regard with acid etch and acrylic resins. But it wasn't until 12 years later that we really saw the composite as such. So two separate components, the glass or quartz particles with the acrylic resin making that composite structure. And again, almost another 10 years, taking us back to Teesside, to ICI, which locally was perhaps better known for the Teesside sunsets, the industrial pollution creating these really striking sunsets for a lot of people on their evening commute. But from a dental perspective, inventing the curing light. So we saw in the mid-70s, Manchester University, the first light-cured tooth-coloured fillings going in place. But thinking back, why to go for composites at all? Why did we move away from amalgam? And with that in mind, we have to think of some of those side effects. Now, we've probably all seen Alice in Wonderland and sort of the Mad Hatter, and that was sort of the feature of a lot of milliners, from rolling felt with liquid mercury on the fingers and it being sort of taken through the skin and causing madness. So we very much saw a trend for amalgam being phased down. But was this for health reasons directly? Were people worried about what it would do in their mouth? Or was it more what was happening in the food chain? And for me, I think it's probably the latter is more significant. So if we look at, say, the Minamata disaster in Japan, where there'd been sort of industrial spillages of mercury and all the fish died, we see a more dilute version of this with sort of industrial pollution heading into the food chain. So what the fish eat, we eat. So it's best if we can limit that. So whether we eat a little or whether we eat a lot, it's best to limit our exposure to these pollutants. So in the same way that a trip to the petrol pumps, you'd no longer see 4-star to symbolise sort of the sale of leaded petrol. We see things moving on, and we're going beyond unleaded now and perhaps look at electrics. So if we think about what's happening in Cuxhaven on the North Sea of Germany, the North Coast, the North Sea coast of Ardensee, and you can see the distinctive Luftfeuer, the beacon on the left of the screen. So we have these traditions there, but very much VOCO being a modern company with new premises. And one of the things that always strikes me when I'm there is how keen VOCO are to work with nature, to the point where the familiar call is the piping sound of the oyster catchers, which nest on the roof there. So looking back, VOCO really pioneered the ormocer, the organic modified ceramic. So in other words, a material that wasn't a composite, it wasn't separate components of glass filler and acrylic resin, but it was a silica resin with silicate filling particles. So all one component, a homogeneous mix. So that was back in 1999. And with 2003, the introduction of nanohybrid. So with nanoparticles rather than microparticles. So allowing a far higher filler content in the materials. And we know that with the high filler content comes hardness, comes polishability, comes stain resistance, wear resistance, all the things that we strive for in restorative dentistry. But it wasn't until 5 years ago when the two technologies were married together with the nanohybrid ormocer and Admira Fusion, which brings us into sort of tonight's lecture well. So with the Admira Fusion, we see that more recent step in that process and no classic monomers in there. So VOCO very much believe if something isn't already available, if it isn't on the market, why wait? The best way to predict the future is to create it. So if we're looking at Admira Fusion and we're looking at its constituents, a good way of looking at that would be with gas chromatography. So to have a look at a graph for a moment, we can see this would be a traditional composite, the competitor's composite as it happens, but you'll see the number of spikes here of the composite if it's in water or if it's dry. And then having a look, if we're checking that in ethanol, you'll see the number of spikes reducing. So that normally shows a product which isn't too stable. So if you note the number of spikes there for a moment on that top graph and how that compares to Admira Fusion. And then again, in terms of its purity, in terms of its stability. to look at how that is in ethanol. So if we go back for a moment, and then having a look at Admira Fusion. So we've got a product that's very pure. And it was quite interesting to me to see how this product was first launched. And the advert showing kind of a ceramic cup, gesturing at Admira Fusion's high silicate content, and ironically a plastic rinse cup. So that's quite key, because it was once said that there'd be more bisphenol A residue, more BPA intake from rinsing from the cup after treatment than there would be from having a traditional composite. But it's not always the presence of risk, but the perception in a patient's mind of the presence of risk. And at the end of the day, not many of us are built with the filters that maybe a seabird like a fulmar has, where we can excrete what we want through our nose. So looking at the formulation of Admira Fusion, we see this unique silicate mix. So with the particles here, the big clusters, and the nanoparticles, and the resin all around there. So as we're breaking down that, the nanoparticles, just to confirm, are silicate. The glass particles are silicate. And of course, the resin, the ormocer resin too. So we've got a really homogeneous material. So as a reminder, the nanoparticles fill every little nook and cranny, every gap in the material, giving a really dense structure. So we can see these images at 20,000 mag, 160,000 mag, and they're so tightly packed, so little shrinkage on curing. And this allows us, in terms of clinical applications, to have materials that are both aesthetic, hard wearing, stain resistant, polishable, all the things that we need at the front of the mouth and at the back of the mouth too. And they're really the features which made me a big fan of Admira Fusion. But in order to do dentistry well, we have to think of other factors. And it's quite apt at the moment in these times of coronavirus, of COVID, that we all think about isolation and self-isolation. But this slide was intended really to symbolize isolation in terms of moisture control, here with the umbrella. But in real life, sort of with the rubber dam, an essential part of adhesive dentistry. So again, not something new. It recently had its 150th birthday, but it took a while, of course, for the rubber dam punch and the rubber dam clamp to catch on. And it's become one of the cornerstones of slow dentistry. And I've had some entertaining and enlightening conversations with my good friend Miguel Stanley about some of the pillars of slow dentistry, whether it's consent, isolation, and key at the moment, cross-infection control. So if these are values you hold dear, it may be worth having a little look online at what Miguel's been doing with slow dentistry. But take us back to the Admira Fusion there. We're going to have a little look now at that in a bit more detail. So effectively, we'll have the world's first direct ceramic filling. And what makes that special? So we've got a material that's light curable. So it's really key to have a good workable curing light, but that could be a whole series of lectures on their own about curing lights. We're not going to dwell on that too much today. But you've got a material with a very high filler content above that 80% threshold. And you can use the bonding resin as well from VOCO, which can be used either selectively or total etch or self etch. We'll touch on that in a moment. But as I say, with the high filler content, it leads to very low shrinkage. And we're sat at around 1.25%. Often dentists like to talk about what the golden sort of fleece would be, what the holy grail of having sort of shrinkage would be. And really, we're never going to get that restoration below 1% in my opinion. And if we are looking at zero shrinkage, we have to go in direct inlays, crowns and so forth. But it's that filler content which gives us that low shrinkage. It gives us that strength, that hardness. So here coming in at 140 on the Vickers hardness scale. And you can see how much harder that is than some competitors' products. So giving us great edge strength at the front of the mouth and significantly on posterior restorations where the forces are certainly higher. And look at edge strength specifically coming in at around 170 newtons there. So looking in practice, what can these materials do for us? So just a couple of things just from day-to-day work. So as I say, I'm very much a wet-fingered dentist. I'm not especially an academic dentist. So having a look at some occlusal restorations here in an upper sextant, or look at some matrices maybe involved. There's a class 2 here, a couple of occlusals, and look at some edge repairs as well, whether in the upper arch or look in the lower arch. So these are materials which allow us to work quickly, cost effectively, and they're easy to repair, relatively speaking, to doing indirect ceramic work. But we don't live in a perfect world, and sometimes we might recommend treatment plans, say for orthodontics or porcelain work, but it just doesn't fit a patient's time schedule or budget. Or with elderly patients, can they lie back? Can they open wide enough? Can they stay still? Have they got Parkinson's, dementia, what have you? So here we made some quite simple changes with some tooth whitening and some direct restorations just to help deliver what a patient wanted. And a lot of this work comes from taking clinical photos and doing real consensual treatment planning, having that co-discovery. Are you aware of the wear in your mouth? Were you happy with the cracks? Were you happy with the shade? And by asking these questions and take it together step by step with your patient, it opens up the opportunity to deliver what they want, essentially. But that was with the packable Admira Fusion. And as is the trend, we've got a flowable version of this product too, which can be suitable for other applications. So having a look here, the material behaves very similarly, but what would be typical is that lower filler content, often a little bit below 80%, 74 in this case, and packable again to sort of 2 millimeters. And with the curing times for the lighter shades, if using a 1000 milliwatt lamp, you're looking at a quicker cure than with the darker shades, the more chromatic shades there. So look at some of the applications here. This was an injection molding case where someone did not have the budget for porcelain work, they declined orthodontic work, they declined tooth whitening. So we took some molds and we did a diagnostic wax up to get approval for the case. And the wax up was used to create a stent. So we had a little look and did a little bit of gingival recontouring. I used electrocautery for this particular case. So we allowed a number of weeks for things to heal. And then we've injection molded with the Admira Fusion. And this is immediately post-treatment. This is how wet fingered. These aren't sort of necessarily what you might call Instagram or influencer type cases. These are real people in the northeast of England. And it just gives us a guide for Admira Fusion. If we're looking back for a moment though, GrandioSO, the composite from 2003, the nanohybrid composite, was upgraded in a way to GrandioSO. And what makes that different to the ormocer, we lack that homogeneous mix. So when we're looking at things there, we've got the resin, we've got the glass and we've got the nanoparticles, but the glass and the particles being one material, the resin being different. So it's very much more like a road surface, like tarmac there. You might have the road stone and then holding it all in place, the bitumen, the road tar. So look at that in more detail. You've got the traditional resins like bisphenol glycerine methacrylate, but you've got a super high filler content, 89%. So really dense material, and these clustered particles of maybe 20 to 40 nanometers, and the larger glasses of around 1 micron, all filling the gaps. But of course, you've got other features like pigments, you've got the camphorquinone, the photo initiator, the thing which allows the filling to set the curing light, and other things there which help the material to be stable and not to go off. But thinking what we want to stencil from our materials, there's a whole range of features there that we are after. So whether we're looking at strength or low stress, curing times, resistance to light and so on. So look at stress around the margin. You want something which is low shrinkage, so less than 2%. And GrandioSO still clearly meets that objective, and it behaves very much like dentine with its elasticity. And as the tooth gets hot and cold with coffee, with ice cream, want something that's going to respond in a very tooth-like manner as well. And want something that's going to be strong. It's going to be hard wearing, it's going to be long lasting, it's not going to be at risk of chipping. And want it to behave well. So if people are having a coffee or a nice glass of red, maybe from Stellenbosch, I don't know, we don't want that to cause any problems with staining. And the polishability, again, coming from the high level of filler, and meaning that the material can keep its gloss, it can last well, and really give kind of porcelains a good kind of bit of competition there. And of course, want it to feel good. So we'll all have our preferences. Some of us like more packable composites, some of us like maybe more buttery, melty sort of composites. And it's really a thing of personal preference there, but what's sure is want something that will handle well. And as well, a range of products now. So we've got a new introduction onto the VOCO sort of stage here with the light flow on the left-hand side and an older material, the flow now, and heavy flow. So I'm just going to summarize some of the uses of these products because they will cover a range of applications. So pretty much what you want a filling material to do, it will do now, but it's a case of making sure you select the right one. So the basic chemistry is going to be the same, but these more flowable materials tend to have the 1,6-hexanediol dimethacrylate HD DMA added to them. And we can see the filler content varies depending on the viscosity. So these low viscosity materials, very flowable materials, like the light flow and the heavy flow, which is almost as highly filled as a packable there. So the low viscosity materials far better for these little areas like hyperplastic areas in teeth or hairline cracks almost. We can spot seal them now, very precise application, where the flow can be used for smaller occlusal cavities and class 3s even, and for repair work. But the GrandioSO heavy flow, really more a load-bearing one. My favourite for periodontal splinting and immediate replacement bridges. So if we've got, say, a tooth that was extracted due to periodontal disease and want to harvest that tooth and refix it to the neighbours, maybe with glass fibres like VOCO Grantech, this would be the perfect material for doing that. So if we're having a look at how GrandioSO looks clinically, you'll find that still gives very acceptable results. Here we've got a patient, a male patient about 80 years old, referred to me by his wife. She's sick of looking at him basically. And after removing some stain with the AquaCare, the soft powder system, and actually just recontouring the teeth, replacing old restorations, leveling the biting edges, it gave them a very affordable way of delivering a result in a short time. So single stage treatment and away we go. But of course, when we're taking the after photo, it also highlights the amalgam there in the neighbouring teeth. So it's sowing the seed for maybe some posterior restorations to be changed in future. And with that in mind, we see here another patient where we can even do quite large things, maybe a bit adventurous, replacing a cusp there with the direct material, but with a favourable occlusion, all good. And having a look at another quadrant in the same patient there. So with that technique in the posterior region, we need to be aware of a few things early on in terms of cavity preparation and making sure we've cleared the aprismatic enamel, we've got a gentle cavo surface angle, and we're not kind of blowing bond and allowing things to pool to try and avoid grey lines. And although this next slide showing beveling in the anterior region, if we just kind of roll our margins and just gently taper things off, it allows for far more harmonious integration from an aesthetic point of view. But if you're wanting to know more, we can always leave that to the expert here with Newton Fall from Curitiba in Brazil. But other hints for kind of getting rid of those grey lines may be making irregular margins. So if we look at the front of the mouth, sort of class 3s, just giving a really irregular, what we might call a starburst bevel there, but again, well described. But sometimes there can be problems with curing and just checking occlusion, check that you're not finishing on a margin. So a good quality articulating foil or paper is key. So probably my two favourite products at the minute are the Troll foil, an 8 micron foil, the equivalent of shim stock, but it marks, and the Bausch 40 micron foil, another favourite. And having a look, giving neighbouring teeth protection when we've got the rubber dam on from maybe when we're sandblasting. So we don't want to be etching and bonding neighbouring teeth and sticking together. We don't want to be ruffling things up with the air abrasion. So the rubber dam, the PTFE, both are key in those areas of the mouth. And a favourite product in that regard, I've used a few, the Orthoblaster from Unident, but our current model is the AquaCare Twin from Velapex, which has a great range of powders, and the 29 micron being my favourite, just for finishing off in intaglio, like the lining of the restorations if for extraoral, or the cavity floor and so on, just removing any aprismatic enamel at the margins. But for stain removal, things like the sodium bicarbonate if there's heavy staining, or the soft, and again, sort of well-proven techniques. And pretty much a Buenacor memorial lecture, thinking of Buenacor and the original sort of white fillings in the 50s and his heritage in that area. But air abrasion alone isn't enough to hold a filling in. We need to think about a bond, not necessarily James Bond though. Futura Bond might be a better option. And this is a product we can use pretty much anywhere you want. So depending on your method of etching, if you want to self-etch, it's all good. So just apply that directly to the tooth, but you're going to get a slightly lower bond strength than if you do apply an acid etch. So is that a selective etch where you're just etching the rim of the enamel, which may be for 30 seconds? And one of the things the chemists at VOCO would normally recommend is rinsing for far longer than most people would in practice. So if you're etching for 15 seconds, maybe rinse for 15 seconds. But if it's a bit longer, just rinse a little bit longer. With the total etch technique, remember, just etch the enamel longer than the dentine as well. And one of the key things there, not to dry things out. So again, there's plenty of literature about wet bonding, well-established technique, pretty much from 30 years ago now, my friend John here. And a good way of thinking of that is to think of the beach and think what it's like when you spot seaweed on the beach. So if the tide's out and the sun is shining, which would be nice here at the moment, it's raining quite heavily in the northeast of England. So dreaming of a sunny beach is quite a nice prospect. The seaweed will look quite desiccated and wiry, but imagine when the tide comes in, the seaweed springs to life, it fluffs up, it becomes, the water flows between it. And that's really what we need when we're looking at the dentine. We want that dentine to be fluffed up and want it to be able to be bonded onto well. We don't want it crumpled. We don't want to be bonding onto that wire wool looking stuff. And we have to think sometimes other things affect the dentine too. And perhaps the most common one would be tooth whitening. So everyone likes a bright smile these days, but one of the side effects of the whitening would be that we're looking at hydrogen peroxide decreasing adhesion. Calcium oxide is forced and it blocks adhesion sites, and oxygen prevents a complete cure of the resin. So if we think why we use glycerin gels and so on to inhibit the oxygen, so when bleaching gel's breaking down, it's forcing that oxygen delivery and it causes problems. So the solution to that's very simple. Where appropriate, wait 2 weeks, and that'll also allow you to match your shades better, as well as improving adhesion. So sometimes just a little bit of patience pays off. And just think it's a bit like a pint of Guinness settling and the bubbles rising to the surface. We just need to get the oxygen out of the dentine. But that's not the only type of bleach that dentine might be challenged by. We see hypochlorite too with the endodontist. So again, this can cause problems with the collagen fibers that we need to actually hybridize with to bond. So this is something that's been sort of a pet topic for me over the years, and I've asked a number of people in different fields. Angus Walls, a gerodontologist at Edinburgh University, who's one of my old restorative lecturers 25 years ago. Didier Dici, professor in Geneva, and John Cankra, of course. So with that, the opinions varied greatly from removing maybe 50 microns of dentine that might have been affected by bleach to maybe 300 microns, who knew? Or not even bothering with the resin and just using a traditional cement, maybe zinc phosphate, perhaps to glue a post in. But as part of the VOCO International Fellowship Symposium, this was actually an area that was studied by one of my colleagues, and that figures about 170 microns. So it's just being mindful that if you are bleaching a root canal, the post channel, that it is necessary. It's going to need a little bit of preparation if wanting to glue in maybe a fiber post. So with the instrumentation there, the composite would be applied in my hands quite often with the titanium nitride instrument, but there are a number of good products. I'll not particularly focus on the Cassie there from Cosmodent tonight, being a more anterior instrument, but this is the sort of typical kit. I've got the yellow metal of the titanium nitride, but another kit that's very popular is sort of the LM Arte kit, which has some very elegant tipped instruments as well. And just in terms of making sure the materials are set, using sort of gels for oxygen inhibition. So with that in mind, sort of the glycerin or oxalate gels, which can be bought as dental products, or some people choose to use other general alternatives that you see lower down the list. But of course, good polishing is key too. And with that in mind, look at the Demonto polishers from VOCO, an excellent choice. Or some of my other favourites at the moment are the wheel-shaped polishers. So things like the Shape Guard from Coltine is a good choice too. And these I would tend to use rotary at quite low revolutions, maybe 6,000 to 8,000 revs per minute. And with the water spray, of course, and just a very gentle sort of intermittent kind of staccato motion. So that would give you a typical profile of the heads of those. But of course, making sure we've got good interdental finishing too. And with that in mind, it might be a case of using metal strips. So for example, the Vision Flex type strips, or perhaps using plastic back strips, thinner strips that can get a finer luster. So the Epitex from GC being a great choice there. And we have to think about what happens after our restorations are placed as well, because sometimes pastes, prophy pastes that might be in our hygiene department could perhaps be a little bit damaging to the restoration. So we need to think about the RDA, the radioactive dentine abrasion index. So the lab test here would be to have an irradiated tooth and to do third-party wear. So we're using a brush and we're repeatedly brushing with the paste, and we're recording the radioactivity of the dentine slurry that's coming off, hence the RDA. So as we're heading up towards 200, we've got very coarse pastes. At 250, we're certainly going to be cutting enamel. We're going to be wearing dentine at far lower values than that. 130, typically wearing dentine. So we've got these products just under these thresholds here, or the green from the Clean Joy series. It's a very gentle paste, which is suitable for everything, almost as soft as baking soda. And with that in mind, a lot of these softer products, baking soda and the like, are more often delivered not by a rotary brush, but by devices like this. This is what my hygienist would use, sort of an air polishing system. So if we think about how we place these materials, now we've thought about how to look after them, starting with the end in mind, I'll run through a series of case studies now. So perhaps one of my favourite kits would be the PALODENT, which I knew in its guise as V3 from Triodent, a small independent New Zealand-based company, but now part of the Dentsply Sirona family, but rebranded and with a slightly different look. So a 3-component system with a tabbed matrix at 4.5, 5.5 or 6.5 millimeters. So just using a periodontal probe to size up for the depth of your box, a ring to hold things in place, and a wedge to support things. And this case being with the packable Admira Fusion, which available in compules or available in syringes, depending on what we're looking at. I personally prefer packable in just the compules. So look at the pre-op situation. We can see 3 teeth which are carious here. So the second premolar, first molar, second molar, and a few interdental areas. If we look at this first molar, the tooth in the center for a moment, just make a mental picture of the distal on this tooth here. So have a look at how bulbous that distal area is, because it almost caught me out. So the first step, good isolation. Get the rubber dam in place. Here we've got that in place with a couple of clamps on the first premolar, the second molar. Cavity preparation. Clear the caries, and we've had a little look air abrasion wise here as well. So when I'm saying air abrasion, we've air polished with the bicarb, the baking soda, and we've also used aluminium oxide for the grit to finish off the cavity floor. And we've rolled our margins, everything's all well and good. The matrix is in place, so here we've tabbed up the premolar, and we've also had a look to build up the wall at this stage on that premolar, and just in sequence heading through. So often we talk about this race to class 1 and just getting the walls up, getting that external form. It makes it a lot simpler to restore. So typically I would restore cusp by cusp, reducing the configuration factor stress, the C factor. And we can see here with the basic pattern in place, few wedges still in position just from when we've had the V-ring, the PALODENT matrix system in place, and also just pinning back the dam, giving me a helping hand. And then finally, all polished. So looking at that after shot and look at the shape, how faithful that is on that first molar, the distal box, that really threw me looking at my after photo and really had to cross-reference against the pre-op. Just it looked such a strange shape on the cusp there at the time. The second case, we'll look at something a lot more simple. So in some cases, maybe we don't struggle getting the tightness that we need from a tab matrix, and a 360 band might be desirable. So here a band from the UK, the Pro Matrix from Aztec Innovations in the northwest of England. And we see some straight bands which have a little cider. These are akin to sequelant bands, very traditional band, or there's a curved version which is a more recent introduction. And we're seeing a case here again with the packable Admira Fusion for consistency. And also utilizing the flow. So think about lining the cavity for wettability or for adapting the matrix band to get a perfect seal. So the pre-op situation, not much to see here. It's often hard to pick out caries, particularly on the younger patients, but some areas which we detected on bite wing radiographs, which unfortunately aren't in the slide deck this evening. And starting with isolation, some quite tight spaces, going for narrow wedges here, and also the wedget from ROCO, just helping to seal things there. And with the cavity preparation, it becomes more obvious where caries been. We see a bit of affected dentin there. And having a look just to adapt to some of those hits and steps in the cavity floor with the flow. You'll note the matrix on the molar here is distorted, and that's would have been corrected. It's just with the occlusal plane mirror, one of the flaws of taking photos as we're working. And having a little look in between, so to speak, the second premolar. So going back for a moment, we don't have all the bands on at once. And then building up cusp by cusp, and finally freeing the patient of the rubber dam, and the final polishing with the techniques, the steps that I've outlined earlier. Another case here with the Pro Matrix. So again, it's that reminder with the regular straight-sided sequelant type Pro Matrix, or with the curved. And this time with the bulk fill. So in the UK, we're seeing bulk fills becoming very popular with dental therapists, and a lot of our state dentistry, the National Health Service, using bulk fills. It's a bit more of a fast fix, curable up to 4 millimeters, and often a less pricey sort of product as well compared to some of the more aesthetic composites. So with this, the advantages are it's fast, it's still got low shrinkage despite the 4 millimeter increments, which gives you great marginal stability. And with it being so translucent, often these products, if you're unfamiliar with them, they have the appearance almost of a drop of milk in a glass of water. And that allows curing to the greater depths with the same sort of levels of photo initiator there. And if you've got a healthy looking tooth with a good chroma to it, a good hue to it, it will pick up on that and blend seamlessly. So look at these products, low shrinkage, and work really well. So this was a chap about 85 years old. So time's not on our side in terms of the appointment. He's had a stroke, he struggles to stay open, but he's suffering toothache, and what can we do but help him? And we noticed some cracks in the lower first molar, the lower second premolar, and we had a little look to investigate following the usual diagnostics. And isolating and preparing the cavity revealed some quite deep boxes here. And we decided to restore both with a bulk fill to save the build-up with those deep increments. So we had a little look to air abrade to improve retention and just the final cavity finishing. We placed the matrix and we used the flow, the Admira Fusion flow, to seal the margins on the matrix. That was quite a challenge in this case with the depth, particularly on the distal of the 6 there. And as soon as we've got the walls up, we moved on. So I'm maybe not using the bulk fill, the Admira Fusion Extra, in the way it was intended by doing sort of strictly 4 mil increments here. But it means that if I'm working cusp by cusp, I'm getting the advantages of that technique without the worry of, am I going over 2 millimeters for the light curing of my increments? So box in, wall up on the premolar tube, and as I say, quite a challenging patient to work in. So the anatomy, the cusp shapes and so on look a bit more rudimentary, and just a quick finish with the 1 step with the Demonto points here and the occlusal control. In fact, you can see some of the red marks on the first premolar there. Sometimes though, it's difficult deciding what to do in terms of matrix bands, particularly when the rubber dam is in place there. And with that in mind, this is a case that I ended up doing the last standing molar freehand. Again, using the Admira Fusion Extra here. This was because when we picked up on this tooth, some of the symptoms, we looked with a tooth sleuth, or what you might know as a frac finder, isolating individual cusps of the tooth and working out that there was a hairline crack in the base of the cavity. Now, we might be thinking about endodontic treatment, extracoronal coverage, but the patient didn't want to invest their time or their resources in having that treatment done until they knew the tooth was stable. So we proceeded on that basis and found the crack, and we had a look at the cavity preparation. And having a little look there, there wasn't a great deep box. The hairline crack wasn't complete, although it was stained, there was no pulpal involvement. I've recently seen this patient, I think, for a 2.5 year or maybe even 3 year review, and things all going well. So you can see how even with some staining in the floor of the cavity there and building that material up, this is the kind of quite translucent material, things are all going well in that regard. And to this day, that's sort of how the tooth's looking, this immediately post-operative, see with the troll file. What would I have done differently there now? I think this is one of the things with dental photography, you always learn from your mistakes or learn where you can improve your techniques. And I think my secret weapon for last standing teeth now would invariably be the HALLERKLAMMER, sort of a rubber dam clamp, which effectively pins back the last standing tooth and frees it up allowing far easier placement of conventional matrix like the Pro Matrix, a 360-degree matrix. And that about wraps things up in that regard. So it's a little review. We've got packable materials, which are either conventional bulk fill, and we've got flowable materials, which are conventional bulk fill. Probably the one which I tend to use least in that regard would be sort of the bulk fill flow. So if any of you've used materials like SDR or SureFill, as it would be in the US, this would be the VOCO equivalent, but as an ormocer, a bulk fill flowable. So really, in summary, you've got materials for every occasion, varying viscosities of flowable, packables, bulk fill or conventional. But sometimes we don't work direct in practice, and it's knowing the limits of these materials. And sometimes that can be doing a little bit of design. So undoubtedly, many of you use DSD, sort of here with my friend Chris Coachman from Brazil. And our cases might need a little bit more planning. So typically it's knowing the limits. So often where there might be existing work on the left here, we had sort of a 10-unit ceramic case where someone's already had a bit of a attempt with some composite to camouflage things, or looking on the right where there are congenitally absent canines, and it was clear that the patient wasn't going to take on an orthodontic treatment program. And just with the design and the planning, we're needing a bit of a helping hand from the lab, from the software, and some very acceptable results here with sort of Emacs, just to give you a guide. But VOCO very much heading into the future, and with scanners and with mills and with printers. So here you'll see sort of the Sulfax material, and you'll note the Luchtfeuer, the light beacon, which we saw as the slide deck moved into Cuxhaven. But sometimes as well, single shade composites don't cut the mustard, and we need opaque or translucent materials. And we'll see a couple of cases here with an alternative product, in fact, a microfill, the Amaris product, which has opaque and translucent shades, and working with the Final Touch color accent kit. So on the left of screen, we can see some very obvious little areas of translucency. We can see that spaghetto, that single almost pasta noodle around the outside of the tooth, the opacity on the outside, and very much a lot of surface texture. So we might be thinking about paste polishing here, which we haven't touched on, with focusing more at the back of the mouth this evening. But these products presented typically in syringes, although they are available in compules too. So the Final Touch is wonderful for using things. If you're highlighting cusp slopes in the posterior, the white is fantastic for that. The brown and the orange, particularly for fissure patterns, and the yellow, typically for necks of teeth, orange sometimes for necks of teeth in the anterior region. So with older patients, they can really be a get out of jail card when budget doesn't allow for ceramics and the artistry involved in indirect restorations. The blue, often for highlighting incisal halos. So if we are getting real translucency, that can be great to breathe life into restorations. So I think that pretty much wraps things up for this evening. So as the sun sets over the Luchtfeuer in Cuxhaven, the sun has certainly set here now. The hour's just gone back with it being the autumn here. And one of Teesside's more recent additions in terms of the bridges, we've got the Infinity Bridge here just up the River Tees in Stockton. But one thing's for sure, with materials like Admira Fusion, and the purity of that ormocer chemistry, we're certainly not seeing the T-side sunsets anymore, or not to the same degree. So pollution in the environment's going down, and as dentists, we can certainly play our role with the careful selection of materials. So that about wraps things up. And thank you all for listening this evening. It's been a pleasure.
Thank you, Dr. Robson. Thank you for introducing the material to us. As I said, I haven't actually come across or been exposed to it, so it's fascinating to see how the chemistry is working and how you can manipulate that and use that within your own clinical environment. Some very interesting cases. Always great to see how it gets done in the practice. There's so much stuff going around on Instagram and all over the world that you sometimes lose touch with what is the harsh reality of what we work in. And it's great to see that you bring that to us, something that we can use tomorrow in our own practices. Thank you very much for that. I'm going to run through a couple of questions that we've had already coming through the panel. I think let's go have a look at what we have right now. Two interesting questions that came up quite early on is the first of all is the bonding agent that needs to be used with Admira and whether it is compatible with any of the other bonding agents out there at the moment. If you could just clarify that for us.
Yeah, of course. The Admira Fusion range is compatible with any bond you choose. So whether it's a conventional bond, which is based on the acrylic family of resins, BIS-GMA, or not. Personally, I don't tend to use the Admira bond, but I would tend to use FUTURABOND U. So the FUTURABOND U is free of those conventional resins, as it's based on, I can't tell you exactly, it's top secret, but it's very similar to 10MDP. So if anyone's familiar with the Panavia kit, for example, it's similar to the chemistry there. So you can be assured that it's a strong bond. I prefer that also because it's a unidose product. So it's in a little blister pack which can be popped, so the chemistry is fresh every time. There's no worry about keeping it in the fridge or keeping it in the surgery. Not that we have some of the hot weather that you might have in South Africa. And you can be assured with that it can work in any way you choose. So whether you prefer to etch or not, selective, total etch, or allowing the bond itself to etch for you, that's fine. All options are good. I use it in place of silane on occasion for priming my ceramics and also for bonding to metal. So for example, if I'm masking over a metal post crown or something, I'll use that and maybe opaque out with a pink or a white composite to hide an old post and core. So really versatile product. It's been a game changer for me.
Thank you very much. Also believe that it helps to stick with the bonding agent that comes with the resin. You just kind of know that is generally the way that most of the testing has happened, and that you can trust that is something that will work, was guaranteed to work for you.
So in terms of that, the resin in the FUTURABOND U has a great affinity for calcium, for dentine, but it's important to make sure we're not over etching if we are etching, and that we're rinsing well and not over drying, keeping that wet or gently moist substrate. So perhaps using a light puff from the 3-in-1 air syringe, or holding an aspirator close by using cotton wool, but certainly not making the substrate sandy and frosted in appearance. The FUTURABOND U, I tend to scrub for 20 seconds, and that will ensure really good collation, that calcium specific bond. and then make sure that's lightly air thin, so low pressure, light stream of air to evaporate the solvent, and then curing effectively. So as I say, I'll not touch on curing particularly this evening. It would be perhaps a series of lectures talking about light curing alone, but just making sure that's cured and knowing the power of your light. A lot of standard lights may be in the range of 1,000 milliwatt to 1,400 milliwatt. Personally, I've used things like the VOCO Cellulux 3, or another favourite is the UltraDent Velo, which has some very high-powered modes, but not for the uninitiated. It does require a bit of a culture change to use a Velo.
Thank you. Another question from Lance was the abrasiveness of these materials to the opposing natural enamel.
Yes. So if we're looking at abrasion, we're looking at a few things. So if we start with hardness, you've got a material where the Vickers hardness is far lower than the natural enamel. The natural enamel would be about 360, and you look at about half that for these materials. So for sure, there are far harder materials. Some of the porcelains may be around the 420 mark for conventional feldspathic, for example. But hardness isn't the whole story, it's about the polishability. So because these materials are nanohybrids, they aren't microfills, you've effectively got a very fine grain with these 20 to 40 nanometer clusters and the single nanometer particles in between. So you can rest assured that these aren't going to cause abrasion. They're not going to wear the opposing dentition.
Thank you. There's a question here from a Norman Clement. He's an older dentist that really believes in using gold foil in many of his cases. His question would be regarding the longevity and biocompatibility with human tissue, and what you see as the longevity of these materials would be or would like to expect when you're using them.
In terms of gold, in my opinion, gold would be unmatched. I was speaking to one of my colleagues, Renzo Vanini, in Italy about this, and he had personal reviews of 40 years on some of his gold work. So gold answers a very different question to ormocers and composites. But with that in mind, Admira Fusion can hold its own. And I've had my practice for 10 years, and I'm seeing cases with Admira and with GrandioSO coming through at the 10-year mark. Time will tell with Admira Fusion. It was launched at IDS in Cologne in Germany in 2015. So I'm only at about the 6-year mark, having been privileged to have this as a white label product prior to its official release. So I've got restorations that are 6 years old for Admira Fusion, but there simply won't be older restorations than potentially mine out there. So it's being careful with occlusion, being respectful of wear. So when we look at tooth wear, we see about 1 micron of tooth wear on an occlusal surface per month, about 11 microns a year. And gold will be malleable, it's soft, it will adapt and it will contour to that. And you won't see that with ceramic-based restorations, whether direct like Admira Fusion or indirect, whether it's sort of the Grandio blocks that have been milled or Ivoclar Emax. These restorations aren't going to wear in the same way. They are harder than the enamel. And key is keeping them well polished and well maintained and glazed, which certainly is more significant with harder ceramics, and particularly with materials like Cavo Everest and so on, like the zirconia based products, really essential to have a good ceramic routine.
Thank you. There was a question here from Andy Efting, and that is if you could please elaborate on the biocompatibility of the fusion material?
Certainly. When we look at biocompatibility, it means different things to different people. So if we look at why people are shying away from composites in some cases, it's because of the traditional resins like bis-GMA. And we look at, say, the US and some of the controversies about bisphenol A, BPA residue, whether it's in a can of tuna, the lining of a lot of canned products, or in a baby's bottle that's been microwaved and fed formula to an infant. So people are getting wary about these resins, and it's remembering that there'll be more of the resin in the rinse cup than the lifetime of the composite restoration. But these traditional resins have gone, and you've got a very inert material in silicate in the Admira Fusion, and as you saw from the gas chromatography, a very select few spikes on the graph. So certainly if I was in a position where I needed any direct restorations, which admittedly few of us as clinicians are because we're careful with our diet, not oral hygiene, I'd have absolutely no reservations in having that in my own mouth. Or we often talk about the daughter test in the UK. Martin Kelleher, a restorative consultant based in London, often looks at the chair as though it's his daughter there and thinks, what would I be happy, what would I be prepared to put in my child's mouth? And certainly, again, I'd have no reservations there. One of the things with BPA and why that's become such a hot topic is people's perception of hormone mimicry with some of these traditional resins and almost the estrogen-like properties that people perceive that they might have. But as scientists, we can interpret the evidence base, the data on these materials, and with good finishing and good technique, we can limit any potential harm. So certainly in my clinic, I'm both using GrandioSO regularly and Admira Fusion regularly. They are my go-to materials.
Sorry, I'll just unmute there. Thank you very much for the answer. I hope that helps you, Andy. And then there was, just moving away from the material choice itself, what is your opinion regarding using transparent wedges in your restorations?
Personally, I wouldn't use transparent wedges because you will reflect light from a metallic band and it will have a synergistic effect. So with that in mind, you'll get a higher light cure with the metallic band. In certain cases, for sure, I use a mylar strip. I use GC's strip roll, and sometimes I'll use that as a static form, other times using what I might call a Wilhite pull. Corky Wilhite, the dentist who works with Cosmodent in Chicago, and maybe prime it up with a little resin and almost use that just to kind of caress around to form the restoration for my class 3s. But generally with the photo initiator content, you can be assured of a 2mm cure and a packable. And if you are using a translucent wedge, it may be to answer a different question. And I would perhaps counter what depth box or what depth restoration you're trying to cure, because I'd imagine it's going to be over 4mm if you're wanting the benefit from a translucent wedge to transmit light.
Thank you very much. Just a last question, which will help unless there are any other ones coming through. Which restorative material is the best choice you would use on a root canal treated tooth, and what is the method that you would choose?
So for root canal treated teeth, unless I've got a 360-degree rim, that would be receiving an indirect restoration in an ideal world. So typically the teeth that might avoid being filled directly might be a central incisor that's had a sports injury and I've got a clear palatal cavity, or maybe a tooth that's had a little impact, say a mountain bike accident, a molar, and it's previously unrestored, so I can have an occlusal small access cavity. With that, I would typically be looking to remove a set amount of dentine to remove the calcium oxide. So using a burr initially to cut back, and if necessary, if I think the tooth has a poor prognosis, I may put a rebuilder post or rebuild a GT post from the VOCO series, a glass fiber post in other words, and typically stabilizing that with rebuilder, a dual cure, luting cement. After that, building up normally with Admira Fusion. If budget and time is of the essence, the Admira Fusion Extra makes a good substrate and is nice to prep the crown. But beyond that, if budget is an issue, one of the techniques that can be great is making something chairside, what I might term an endo crown. And the GrandioSO inlay kit is perfect for this. So by taking an alginate of the prepared tooth, I would quickly chairside pour up a silicon model and then build up a plug, almost like a cork in a bottle, a bit like what you might have called a Naya core in the days of placing amalgam, and use that to have a full coverage, cuspal coverage tooth top, and glue that in place with Bifix typically. So that would be a good alternative for those really on a budget. But as I say, sometimes it does come down to that. I live in the real world, I'm a wet finger dentist. It's not Beverly Hills, it's Billingham where my practice is. So yeah, it is being pragmatic and being aware of these choices.
Thank you very much. It's very interesting. It's kind of the direct, indirect method, chairside, which works very well. Thank you.
Sometimes
if there are no other questions, I'd like to take the opportunity to thank Elmien Greyling from Henry Schein and Michael Cunnies from VOCO for facilitating this meeting and helping it to actually take place. And then, of course, to you, Dr. Robson, for the time and the effort that you've put in, for being here with us tonight and to sharing your knowledge. Love the wet finger dentistry. As you refer to it, it's always something we can take home with us and really start using in our practices the next day. Fascinating material, great to hear about it, great to see how we can use it in our practices. So thank you very much for that. Just to remind everybody about the upcoming meetings, please log into SADO, go look on the Facebook page, go look and see what meetings are coming up. Reminder of David Greer on the 17th of November. That will be held with Men's Health as well. And we look forward to seeing everybody there. With that, I'd like to say thank you and have a great evening, everybody, and hope to see you at the next meeting.
Thank you, everybody. I'm going to close the meeting now. Have a good evening.
Thank you, Marlies.
Thank you.